Hi, Happy New Year. Um, Welcome to our first Barts-MS NeuroSpeak case study. I hope you can all hear me clearly. If not, please drop a comment to let me know. The purpose of this really is to try and go through some management issues in the relationship to the way we manage multiple sclerosis in the modern era. And we're doing this live so people with the disease, their family members, and other stakeholders can watch this so they get an idea of how we manage MS. So you should have gone through the case scenario. This is a Caucasian male born in 1966 who presented with his first attack in February 2005, brainstem syndrome with unsteadiness of gait. Unfortunately, he recovered incompletely and was left with a little bit of unsteadiness. He subsequently went on to have a second attack in 2006, and then I started on treatment of interferon beta. Then I went on to have multiple relapses despite interferon beta before being referred to us in May 2012. When we assessed him, we couldn't get a good history from him, but we could see that he had breakthrough activity. So we switched him to glutarium acetate, Copaxone, 20 milligrams subcutaneously daily. And he subsequently went on to develop progressive disease from about July 2013. As you can see, his scan shows a high lesion load. He's already got some macroscopic or obvious brain volume loss with large ventricles and obvious sulci. You can see the ventricles are enlarged sulci. And when you go to the back of the brain, this is the cerebellum and brainstem, you can see he's got a very high lesion load in the posterior fossa, which would explain why he's unsteady in his gait, and there is some shrinkage of the brainstem. So the questions I proposed was, what type of MS does this patient now have? And you've all responded to these questions. So focusing on question 1. So most of you, it's almost 60%, when I closed the survey yesterday, said that he has active secondary progressive disease. Now, the classification of MS has changed. Up until quite recently, we were using the Lublin-Reingold classification of 96. And that would have actually said that this particular individual had secondary progressive disease, but he was still having superimposed relapses. That would imply activity. However, we could not get any history of ongoing relapses in this gentleman. So in the old classification, I would have said he had non-relapsing secondary progressive disease. If you look at his clinical course, you'll see he went through a relapsing remitting phase. He was going through a phase where he was getting worse in terms of disability progression because his EDSS score was going up from 2 to 4, 4.5 and 5, and he had sequelae and incomplete recovery. And since about July 2013, we haven't been able to document any relapses, and he's been gradually getting worse with no new active lesions on his scan. So we would call this secondary progressive MS inactive, and this actually refers to the modern or the most recent classification system that was published in 2014, where the Lublin criteria divides people up into relapsing disease and those with progressive disease. And the progressive disease, you can either have primary progressive or secondary progressive, and this is defined by your onset. So if you start off with progression from the beginning, you call primary. If you have a relapse onset disease, you call progressive. And then we define whether or not patients are continuing to progress, in other words, get worse with or without relapses. So if you have relapses or MRI activity suggestive of ongoing inflammation, we would say you have active. So he is non-active, but he is getting worse, so it's with progression. So under the new classification system, this patient will be classified as having inactive secondary progressive disease. Quite complicated, but I think this new classification system provides us with a framework for considering the use of anti-inflammatory disease in people with progressive MS. So if somebody has got progressive MS and they're continuing to have superimposed relapses, or on MRI monitoring, we're seeing new lesions or GAD-enhancing lesions. In other words, they have active inflammation on scan. They may be eligible, or almost certainly eligible, for some of the disease-modifying treatments that target this process. Baseline prognostic profile. So most of you said he had just over half said he had a poor or unfavorable prognosis, with a significant proportion saying intermediate. Now, there are no hard and fast rules here. So if you look at the poor prognostic variables that I've posted on our blog many times, going from older age of onset, and you can see I've marked with a cross those that he has. So older age of onset, he was 40 when he presented initially. He was male. He had an efferent system. In other words, his first attack was cerebellar, difficulty walking. He had a high relapse rate within the first 2 years. He had substantial disability after 5 years, and he had an abnormal MRI, and his abnormal MRI showed a large lesion load, GAD-enhancing lesions, and lesions in the so-called posterior fossa, that's the brainstem and the cerebellum, and his lumbar puncture showed that he had bands. So he had quite a few poor prognostic profile, and based on this, I would have classified him as being in the poor prognostic group, which would influence the types of treatments we would consider now. Would you have managed his MS differently in February 2005? That was when he presented initially. And most people said yes, and I'm very reassured to hear that. 63% of you said yes, compared to 37% saying no. And I think, most people now would start people with a clinically isolated syndrome, with an MRI with GAD-enhancing lesions. So this would now, in the modern era, 2015, be classified as having definite MS based on the current McDonald criteria. And I think most neurologists specializing MS would offer people a disease-modifying treatment from the beginning. And I think there's data to support this. So this is the early treatment paradigm, and this is just real-life data from MS-Base. So MS-Base is this large database that's run out of Melbourne. And you can see that when you look at this top image here, top left-hand corner, we can see those people that received treatment for the majority of the time, yellow bar, versus those with no treatment. And these are people presenting with their first attack, do significantly better over time. And this is an 8-year period. So I think, the data now is overwhelming in support of starting treatment at the clinically isolated syndrome time. And it doesn't matter how you cut this data. This is proportion of disability progression-free. This is looking at the inverse. This is looking at the proportion of disability progression-free. Looking at the medications there. All of it points in the same factor. Those that offer treatment earlier, get onto treatment at the clinically isolated syndrome stage, do better. What about between October 2006 and May 2012? So this was when this gentleman was on interferon, and he was continuing to have active disease. In other words, he had suboptimal response to interferon. And so the majority of you said yes. This is over 70% said yes, you would manage his treatment differently. And the majority of you were discussing switching therapy upwards or sideways. What about between May 2012 and disease 2015? So now this is looking at this phase of the disease where he's now been switched from interferon beta onto glutamic acetate. He stopped having relapses, and his MRI has shown no new lesions, so we can't detect any evidence of focal inflammatory activity. But this gentleman is continuing to progress and get worse over time. And so, unfortunately, based on our treatment guidelines in the United Kingdom, we don't really have any data to support treatments working in this phase of the disease that are licensed. And so a large number of you said you would have managed his MS differently in the so-called non-relapsing progressive phase of the disease, where there was no activity, no obvious activity, but the patient was still progressing. And the only drug we have licensed or recommended by NHS England to treat people in this phase of the disease is beta interferon, but it's only licensed for people with secondary progressive disease who've had at least 2 disabling relapses in the last 2 years. So this gentleman would not have been eligible for a switch because he wasn't having relapses. And also, he had already failed interferon in the past. So, there really was no indication for switching him from glutaric acetate at this stage to interferons. Would you stop his glutaric acetate? And I think most of you said yes, you would. That's 64%. But there was a significant proportion said no, or you'd use another option. And I think the stopping criteria for stopping disease-modifying therapies in the NHS, particularly England and Wales, is the development of secondary progressive disease causing inability to walk for more than 6 months. So this gentleman was still mobile. His EDSS was not that low that he couldn't walk. And we have to assume that the glutaric acetate was doing what it's meant to do, stop relapses. And it wasn't impacting on the progressive phase of this illness.